Welcome to the deep dive. Today we're tracing the intricate electrical journey within your heart.
Yeah, specifically looking at what happens when that journey hits, well, a kind of roadblock.
Exactly. We're diving into atrioventricular block, often just called heart block.
hmm And it basically means there's a communication problem, a hiccup, between the top and bottom chambers of the heart, the
Mhm.
atria and the ventricles.
Right. The electrical signal gets delayed or maybe doesn't get through properly. We're going to cover the three main types today.
We are. Understanding this is really key. If you're interested in cardiac health or maybe prepping for exams like the MSRA.
Definitely vital information. Okay, so three main types of these electrical disruptions. Let's start with the first one. What's type 1?
That would be first-degree heart block. So when you look at an ECG, the heart tracing, you focus on the PR interval.
Okay, the PR interval. That's the travel time for the signal, right? From atria to ventricles.
Precisely. In first-degree block, this PR interval is consistently longer than it should be, specifically over 0.2 seconds, every single beat.
Longer than 0.2 seconds, consistently.
Got it.
It's like the message is always arriving a bit late.
Exactly. Just taking a little extra time.
And what's the clinical picture here? Our notes mention it's often asymptomatic. People don't feel it.
That's often the case, yeah. Many people have it and don't know, and it frequently doesn't need any specific treatment. It's more of an ECG finding.
So a delay, but maybe not a major functional problem in many cases. PR over zero point 0.2 seconds.
Yeah.
That's the key takeaway for first degree.
Correct. Now, things get a bit more complex with second-degree heart block. There are actually two types here.
Okay, let's break those down. What's the first type of second degree?
That's type 1, also known as Mobitz, or probably more commonly Wenckebach.
Wenckebach.
Great.
Right. What's the pattern there?
It's quite distinctive on the ECG, that PR interval we talked about. It gets progressively longer with each beat.
Huh?
Longer.
So the delay gets worse each time.
Yeah, until eventually a beat is completely dropped. You'll see a P wave, the atrial signal, but it's not followed by a QRS complex, meaning the ventricles didn't get the message that time. Then the whole cycle starts over.
Ah, okay. Longer, drop. I remember a memory tip for this one. Wenckebach walks away, like the QRS complex eventually disappears or walks away for a beat.
That's a great mnemonic, yeah. Wenckebach walks away. Perfect way to remember that dropped beat after the progressive lengthening.
Awful for exams, definitely. Okay, so what's the other type of second-degree block?
That's type 2, or Mobitz 2, and the ECG picture is, well, quite different.
How so?
Here, the PR interval stays the same. It's constant, maybe normal, maybe long, but it doesn't change beat to beat.
Okay, so no progressive lengthening like Wenckebach.
Right, but then suddenly, out of the blue, a P wave just isn't conducted to the ventricles. Poof, a drop beat, no QRS.
Intermittent failure then. Not predictable like Wenckebach.
Exactly, and it can happen in fixed ratios sometimes. Like you might see 2 P waves for every 1 QRS, a 2.1 block, or maybe 3 P waves for every QRS, a 3.1 block, or it could be irregular. The key is the PR is constant before the dropped beats.
And our notes suggest this one, Mobitz 2, can be more serious than type 1. Why is that?
Generally, yes. Mobitz 2 often points to a problem lower down in the conduction system, sort of below the AV node in his Purkinje system.
Ah, okay. Further down the wiring.
Yeah, and damage there is, well, often considered less stable. There's a higher risk it could progress suddenly to the most severe type of block.
Which brings us to the third type.
Exactly. Third-degree heart block, also called complete heart block.
Complete. Sounds significant.
It is. In complete heart block, there's basically no communication between the atria and the ventricles. Zero relationship between the P waves and the QRS complexes on the ECG.
So they're just beating completely independently. Atrial rhythm doing one thing, ventricular rhythm doing another.
Yeah, that's precisely it. The atria are usually being paced by the SA node, and the ventricles rely on a slower escape rhythm originating from somewhere lower down. It's a total electrical disconnect.
Wow. Okay, you can see why that would be a problem for coordinating a proper heartbeat and pumping blood effectively.
Absolutely. It often leads to very slow ventricular rates.
Right. So we have first degree, slow PR, second degree Wenckebach, longer drop, second degree Mobitz 2, constant PR, sudden drop, and third degree, complete disconnect.
Got it. Now, what kind of things actually cause these blocks?
Well, there's quite a range of potential causes. A really common one, especially in older adults, is just age-related changes, fibrosis, or scarring of the conduction system itself.
Wear and tear, basically.
Kind of, yeah. Then there are various heart diseases. A big one is myocardial infarction, a heart attack, especially if it affects the area supplying the conduction system.
Makes sense. Damage to the heart muscle affecting the wiring. Exactly. Also, cardiomyopathy diseases of the heart muscle itself and inflammation, like endocarditis, which is infection of the heart valves, or myocarditis, inflammation of the heart muscle.
Okay, what else?
Valvular heart disease can contribute, particularly aortic stenosis seems to be associated. Certain medications are well-known culprits too.
Oh, like what?
Things like beta blockers, some calcium channel blockers, digoxin. These are all drugs that intentionally slow conduction through the AV node, but sometimes they can slow it too much. Even high levels of magnesium can play a role.
Right, so medications are a key thing to check.
Definitely. Also, some people are born with congenital heart defects that affect the conduction system. And then there are inflammatory or autoimmune conditions,
Wait.
like Lyme disease. That's a classic one taught in exams. Also, lupus, SLE, ankylosing spondylitis, reactive arthritis, rheumatoid arthritis. These can sometimes have cardiac involvement.
Interesting, the systemic inflammation affecting the heart's electricity.
hmm And rarely there can be inherited genetic conditions causing AV block, sometimes running in families. Oh, and electrolyte imbalances, particularly high potassium, hyperkalemia, or, as I mentioned, hypermagnesemia.
So quite a broad list. It really highlights how interconnected everything is. Given that list, who's most at risk then?
Well, as we mentioned, advancing age is probably the biggest non-modifiable risk factor.
Right.
Having any pre-existing heart disease, coronary artery disease, heart failure, previous heart attack definitely increases your risk.
Okay.
Taking those medications we discussed that affect conduction, having congenital heart defects from birth, anyone who's had prior heart surgery or procedures, as these can sometimes inadvertently damage the conduction system.
Ah, that makes sense.
And of course, those inflammatory conditions like myocarditis or having a family history of inherited heart rhythm problems.
So older age, existing heart problems, certain meds, previous interventions, those are the main flags. Okay, let's zoom in a bit on the mechanism. What's the fundamental problem? The pathophysiology?
At its core, AV block is just an interruption, right? It's a problem with transmitting that electrical signal from the top chambers, the atria, down to the bottom chambers, the ventricles.
And that interruption can happen at different points along the pathway.
Exactly. It could be a problem high up near the SA node, or more commonly within the AV node itself, that's the usual gatekeeper.
Yeah.
Or it could be lower down in the His bundle, or the bundle branches, that sort of fast wiring system within the ventricles, the His-Purkinje system.
So depending on where the block is, you get different types of AV block and different severities.
Precisely. The end result is either a delay in the signal getting through, or it gets completely blocked, sometimes intermittently, sometimes all the time. This leads to the ventricles beating slower, or maybe not at all in response to some atrial beats, which messes up the heart's rhythm and its ability to pump effectively.
Okay, that clarifies the what and where. Now, if a doctor suspects AV block, what else might be going on that looks similar? What's on the differential diagnosis list?
Good question. There are a few mimics. One is sinus node dysfunction, sometimes called sick sinus syndrome. Here, the problem is higher up. The SA node isn't firing properly, leading to slow rates or pauses, which can sometimes be confused with dropped beats.
So the pacemaker itself is faulty rather than the connection.
Kind of, yeah. Another is bundle branch block. This is a block lower down within the ventricles, affecting how the signal spreads there. It changes the QRS shape on the ECG, but it's distinct from AV block, which is about conduction to the ventricles.
Right. Different part of the wiring.
Sometimes certain fast heart rhythms, like ventricular tachycardia or SVT, can have funny conduction patterns that might superficially resemble some forms of AV block, especially high-grade block. And underlying structural heart defects might indirectly cause conduction issues.
So really analyzing that ECG carefully is crucial to tell these apart.
Absolutely critical. The ECG holds most of the clues.
Now, how common is this? You mentioned first degree is relatively prevalent.
Yeah, finding specific overall prevalence data for all types of AV block in the UK is a bit tricky based on our sources, but it definitely gets more common as people get older and for those with underlying heart conditions.
But first degree?
First degree block is, surprisingly common. Some UK data suggests around 7% prevalence, maybe even higher in older groups, but again, often benign. The more advanced types, Mobitz 2 and third degree, are much less common, but clinically more important.
Right. Prevalence versus significance. Okay. So if someone does have a more significant block, what might they actually experience? What are the symptoms and signs?
It really depends on how slow the heart rate gets and how compromised the blood output is. Some people, especially with milder forms like first degree or even some Wenckebach, might feel absolutely nothing.
Okay.
But if the block is more severe, causing significant bradycardia, a slow heart rate, then symptoms appear. Fatigue is common, dizziness, feeling lightheaded, or even syncope, which is fainting or passing out.
Because not enough blood is getting to the brain.
Exactly. Also, shortness of breath, especially with exertion. Some people might feel palpitations like skipped beats or fluttering, even though the underlying problem is a slow rate. Chest pain is less common, but can occur.
And what would a doctor look for?
Yep.
The main sign.
The key clinical sign is usually bradycardia, just a slow pulse rate found on examination.
Got it. So how do doctors confirm the diagnosis? What tests are used?
The absolute cornerstone is the ECG. As we've discussed, the patterns are usually quite characteristic for each type.
But what if the block isn't happening all the time?
Right, good point. For intermittent blocks, a standard 10-second ECG might miss it. That's where ambulatory monitoring comes in. Things like a Holter monitor.
That's the one you wear for 24 or 48 hours.
Yeah, exactly. It records every single heartbeat over that period, increasing the chance of catching those intermittent dropped beats or pauses. Sometimes even longer monitoring is needed.
What about checking the heart structure?
An echocardiogram and ultrasound of the heart is usually done. It's crucial to look for underlying structural heart disease, check valve function, heart muscle thickness, pumping strength, that sort of thing.
Okay. Any other tests?
Sometimes an exercise stress test is useful. It can see if the block appears or worsens with physical activity. And in certain more complex or ambiguous cases, doctors might recommend electrophysiological studies or EPS.
That sounds more involved.
It is. It's invasive. Catheters are put into the heart via veins, usually in the leg, to directly map out the heart's electrical activity and pinpoint exactly where the conduction problem is. It's not routine, but useful in selected situations.
So a combination of electrical tracing, structural imaging, and sometimes more detailed electrical mapping. Once it's diagnosed, how is AV block managed? What's the treatment?
Management really hinges on the type of block, the severity, and crucially, whether the patient is having symptoms.
So for that asymptomatic first-degree block,
Often just observation is needed, maybe keeping an eye on it with repeat ECGs periodically. No active treatment required in many cases.
and medications, you mentioned some can cause it. Are there meds to treat it?
Generally, no. Medications aren't the primary fix for the block itself. In fact, often the goal is to stop or reduce medications that might be contributing to the block, like those beta blockers or calcium channel blockers, if possible.
Okay, so what is the main treatment for more serious block?
For a significant symptomatic AV block, particularly Mobitz to second and third degree block, the definitive treatment is usually pacemaker implantation.
Ah, the pacemaker. How does that help?
A pacemaker is a small device, usually implanted under the skin near the collarbone, with wires or leads that go into the heart chambers. It monitors the heart's rhythm, and if it detects the heart rate is too slow or a beat is missed due to block, it delivers a tiny electrical impulse to make the ventricle contract.
So it provides a reliable backup beat.
Essentially, yes. It ensures the ventricles beat at an appropriate rate, preventing severe bradycardia and its symptoms. For temporary or reversible causes of block, sometimes temporary pacing might be used until the underlying issue resolves.
And what about addressing the root cause?
Absolutely vital. If the block is due to, say, Lyme disease, treating the infection is key. If it's due to a medication, adjusting the medication. If it's related to a heart attack, managing the coronary artery disease. Addressing the underlying condition is always part of the plan.
Right. So pacemakers are key for the serious stuff. What's the general outlook for someone diagnosed with AV block, the prognosis?
It's quite variable. For first-degree block, the prognosis is generally excellent, doesn't usually impact lifespan or quality of life significantly.
Good to know. And for the others?
For Mobitz Wenckebach, if asymptomatic, prognosis is also usually good, though sometimes it can progress. For Mobitz's second and third degree block, the prognosis without treatment can be poor due to the risk of severe symptoms, collapse, or even sudden death.
But with treatment, like a pacemaker.
With appropriate management, especially pacemaker implantation when indicated, the prognosis improves dramatically. Pacemakers are very effective at relieving symptoms and preventing the dangerous consequences of severe block. The long-term outlook then often depends more on the underlying heart health any other cardiac conditions the person might have.
So timely diagnosis and management are really key for the more advanced types.
Absolutely. Makes a huge difference.
And if it's not managed properly, what are the potential downsides, the complications?
Well, the most direct complication is symptomatic bradycardia, that persistent slow heart rate causing fatigue, dizziness, poor exercise tolerance.
Right, the symptoms we discussed.
Then there's the risk of syncope, fainting, which can lead to falls and injuries.
Hmm.
There's also an increased risk, particularly with high-grade block, of developing other dangerous arrhythmias or even, in the worst case, sudden cardiac arrest.
Okay, and just generally affecting daily life.
Yes, definitely impaired ability to exercise or do strenuous activities, and just an overall reduction in quality of life due to the symptoms and limitations.
Okay, that covers a lot of ground. Let's try and summarize the key points about AV block for everyone listening, especially if they're revising this for something like the MSRA.
Sure. So AV block is about faulty electrical conduction from atria to ventricles.
3 main degrees. First degree, just a slow signal, PR interval, consistently over 0.2 seconds, often benign.
Yep. Second degree, intermittent dropped beats. Type 1 Wenckebach has that progressive PR lengthening before the drop. Remember, Wenckebach walks away.
Right, and type 2 Mobitz 2 has a constant PR interval, but sudden, unpredictable dropped beats, often considered more serious as it can progress.
Correct. And third degree is complete heart block, total dissociation between P waves and QRS complexes. Atria and ventricles beat independently.
We talked about many causes: age, heart disease like MI or cardiomyopathy, meds like beta blockers, inflammation like Lyme, sometimes congenital or inherited.
Diagnosis relies heavily on the ECG pattern, sometimes needing Holter monitoring, echocardiogram checks for underlying structural issues.
And management depends on type and symptoms. Observation from mild cases, but pacemakers are the mainstay for symptomatic Mobitz 2 and third-degree block, plus managing underlying causes.
Exactly. Prognosis is generally good for lower grades, but for higher grades, pacemakers significantly improve outlook and quality of life. Complications of untreated severe block include syncope and, rarely, sudden death.
It really makes you appreciate the incredible precision of the heart's normal electrical system, doesn't it? And how vulnerable it can be.
It truly does. A complex system, finely tuned, and when it goes wrong, the effects can be quite profound.
Indeed. Well, if you want to solidify your understanding of AV block or explore thousands of other high-yield medical topics and questions, definitely check out pastthemsra.com.
And there are great free resources and sample questions available too over at freemsra.com.
Thanks for joining us for this deep dive into heart block.